Let's see an interesting case, a case that refused to fit. A 17-year-old girl with uncontrollable movements. Imagine you are the admitted physician, and a previously healthy 17-year-old girl arrives with nothing more than fever and headache. At first glance, it appears to be another viral illness, or perhaps meningitis. Nothing immediately suggests what is about to unfold. Then everything changes. Within days, she developed violent, irresistible coliform movement involving both upper limbs. The movements become so severe that she cannot control them, cannot resist, cannot rest, and cannot communicate properly. Soon after, her level of consciousness began to deteriorate. Now the renal investigation begins. The obvious question is, why would a healthy teenager suddenly develop chorea? The first suspect is Sydenham chorea, the commonest acquired cause in this age group. We search carefully for evidence of rheumatic fever. A 2D echogram is performed looking for rheumatic valvular disease. Nothing. If it isn't Sydenham chorea, could this be Wilson disease? She is young enough. Copper metabolism disorders can certainly present with movement disorders, but there's no family history, no clinical evidence to support it. An investigation point elsewhere. Could this be autoimmune encephalitis, lupus, vasculitis, an occult infection? The autoimmune workup begins. ANA is negative. Complement level C3, C4 are normal. Active lupus now seems less likely. So, where do we look next? Then comes the first clue. Anticardiolipin antibody returned strongly positive. Soon after, beta 2 glycoprotein 1 antibody are also positive. Interesting. But are these laboratory curiosities, or are they explaining the entire illness? Another unexpected finding appears. The VDRL is reactive. For a brief moment, syphilis enters the differential diagnosis, but confirmatory TPPA is completely negative. Why would that happen? Because antiphospholipid antibody can react with cardiolipin antigen used in VDRL test, producing a classic biological false positive result. That single laboratory discrepancy suddenly becomes another piece of puzzle rather than another diagnosis. But laboratory test alone cannot explain such profound neurological deterioration. So imaging is performed. MRI of the brain reveal bilateral subacute lacunar infarction. Now everything changes. This is no longer simply a movement disorder. The chorea may actually be the consequences of cerebral ischemia. Yet another question arises. Why would a healthy 17-year-old girl develop multiple cerebral infarcts?